Welcome to another video with Paula Anderson, Coaching Consultant. I am your instructor, Paula Anderson, and I want to give you a little bit about my background before we get started with the lesson on anesthesia coding. So I have 2 bachelor's degrees, one in English, another one in journalism with an emphasis in public relations. I have a master's degree, and I am a CPC, CPB, and also a PC approved instructor. So the topic for this coding video today is going to be anesthesia. So anesthesia is a specialty that I coded for about 2.5 years. And it is a specialty that I highly recommend for individuals that want to learn more about, for individuals that want to get an entry-level position in medical coding. So it's very straightforward in terms of how you code for it. Now, since there have been changes, since I stopped coding anesthesia, I recommend that you get with your Medicare administrative contract to find out a little bit more. And then there's also a society that actually regulates anesthesia. So let's get started with this lesson. So anesthesia is going to be the second section that's in the CPT manual. All right, the second section. So one of the things that you want to do when you get ready to do any kind of coding, you want to read the guidelines. And so the guidelines give you a general overview. However, the guidelines do not have all of the coding instruction. So that's one of the reasons why you have to have some other resources to help you. So there are 2 providers that are going to code or bill for anesthesia. And that's going to be an anesthesiologist, which is an MD. And then we have a CRNA, a certified registered nurse anesthetic. So those are the 2 providers that can bill for anesthesia. Now, there are 4 terms that I want you to think about when you're talking about anesthesia. So the first one is anesthesia, of course, which is the loss of consciousness. Then you have an anesthetic, which is the drug that they are administering. Then an analgesic, which is to relieve pain, and then analgesia, which is the painkiller. So those are 4 terms that you want to remember: anesthesia, anesthetic, analgesic, and analgesia. All right, so you can get your medical dictionary and look those up. There are 3 types of anesthesia. The first one is general anesthesia. So general anesthesia is when you are the consciousness, the loss of consciousness to like the whole body. All right, so you shut down the whole body with general anesthesia. Local anesthesia, this can be done with a minor procedure that's in the office. So that's what local anesthesia is. It's bundled into the procedure itself. And then we have regional anesthesia, which is a portion of the body. So it's a region of the body that's being anesthetized. All right, one other concept that you need to be familiar with is monitor anesthesia care. So I'm going to give you 4 things that it focuses on. The first one is medication is administered through an IV line. It is done to monitor patient comfort level. You can increase or decrease medication, and it includes the preoperative, intraoperative, and postoperative anesthesia. Now, there is a modifier that goes with monitor anesthesia care, and we'll talk about that in just a minute. All right, so before you get ready to have a procedure, you're going to have an EM visit that's equivalent to the same thing as, like you said, your center physician. So you're going to have a pre-anesthesia evaluation, which is patient history, physical examination, and preoperative test results. So that anesthesiologist or that CRNA, they're going to evaluate you before you have the procedure done. So that's going to be the pre-anesthesia evaluation. Then once you finish surgery and get up under from the anesthesia itself, you're going to have evaluation of patient. There's an evaluation of patient doing recovery from anesthesia. So that's going to be something that happens at the end of the surgery. Now, one thing that can be requested is post-operative payment. So what this means is that the surgeon is asking the anesthesiologist to perform post-operative pain management because of the procedure that was done. So you're going to have the anesthesiologist that's going to do the actual case procedure, which is the anesthesia, and then you're going to have a second anesthesiologist or a pain management doctor that's going to bill for like a nerve block. So you're actually billing for two procedures. Now, because you're billing for two procedures, then of course you have to have a modifier on the second. But the anesthesia, the post-operative pain management has to be requested and it has to be documented by the surgeon. Now, there is another code that you bill for. We've been doing those follow-up visits of the post-operative pain management, and that's going to be 01996. That's 01996. Now, there are a lot of Hicks-Fix modifiers that go with anesthesia, and so I'm going to go over a few of them in this video. So the first is going to be AA, which is anesthesia services performed personally by anesthesiologists. Then you have AD, medically supervised by a physician for more than 4 concurrent procedures. Concurrent means at the same time. GA, monitor anesthesia care for a deep, complex, and complicated or markedly invasive surgical procedure. You have G9, which is monitor anesthesia care for a patient who has history of severe cardiopulmonary condition. QK, medical direction 2, 3, or 4 concurrent procedures. QS, so this is the modifier that I mentioned to you earlier. That's going to be used for monitoring anesthesia care, and that's QS. Other modifiers, QX, which is CRNA service with medical direction by physician. QY, medical direction of 1 CRNA by an anesthesiologist, and QZ, CRNA service without medical direction by physician. So those are some of the Hicks-Fix modifiers. There are more, but those are just a few. Now, the physical status modifiers. So you have your P1 is home health patient. You have P2, which is patient with mild systemic disease. P3, patient with severe systemic disease. P4, patient with severe systemic disease that is a constant threat to life. P5, war-bound patient who is not expected to live. And P6, which is patient declared brain dead. So the anesthesiologists, because they are the ones that's actually with the patient, they're going to assign the physical status modifier, because you as a medical coder, you're not in the operating room when they're doing a procedure, so you don't really know all that clinical detail. Now, the CPT modifiers that are associated with anesthesia. So modifier 23 is unusual anesthesia service, and that means that anesthesia is normally not required for that particular procedure. 59 is distinct procedure service. And we know what 59 is, that you have to have 2 or more procedures that are being done that has a distinction. They're not related in any way. Then you have 74, which is discontinued outpatient hospital ambulatory surgical center procedure after anesthesia administration. So I've never used this modifier before in the past. We would just bill the procedure, even though if the procedure had been canceled, we still, and if the anesthesia had been administered, just bill for the anesthesia. And then 99, which is multiple procedures, and I'm not going to go into a whole lot of detail on that. So those are just some basic guidelines or some basic things that you need to know about anesthesia. Stay tuned for another video with Paula Anderson teaches medical coding, and we'll go over some other aspects of anesthesia coding in the second video. Stay tuned.